There you go.
Great. So welcome everybody to our community conversation on postpartum sex. I'm so excited for this conversation with Dr. Juan Michelle Martin. On Instagram, you're at the Pelvic Perspective. Yeah. So we'll put that in the chat box, but at the Pelvic Perspective. And I've just been following her for a long time on social media and reached out with a hankering for someone to take this topic on, because even at Birthsmarter, when we teach childbirth ed and fourth trimester planning, at most we'll say, hey, just a heads up, you don't have to have sex at the 6-week mark, but we don't go into it more in terms of how it might feel or what you might want to prepare. And the only advice I've heard anecdotally being thrown around by our students is to get really drunk before you have sex for the first time. So I want to throw that out as a conversation starter, because part of me thinks it could be really helpful and part of me is wait, what else are we dealing with here? So I just want to throw it over to you and thank you for being here and for chatting with us. And if you've not, for everybody else in the room, if you haven't been with us before, Dr. Juan Michelle is gonna do a short presentation, and then we really want to have an active conversation, discussion, Q&A. So anything that you say on the video will be in the recording, but you can type things into the chat box and I won't share that. Or you can just message either of us privately, and then nobody will see that the question is from you. So that might help, especially given the topic. Okay.
So, I would like to hear from some of you guys. What are some of the things that you have heard with regards to sex after having a baby? And also, what are some of the things that you've heard with regards to painful sex after having a baby? So drop those in the chat for me, if you will. Use lidocaine cream before sex to help with pain. That also can get on the penis, so you might lose some sensation there. Let's see. I have heard nothing. That is a lot of women. That is absolutely a lot of women. They haven't heard a thing. We got a couple people saying they've heard nothing. So I'm going to jump in first by just giving you guys an introduction. My name is Juan Michelle Martin, Dr. Juan Michelle Martin. I'm a pelvic floor physical therapist, also birth doula in the Atlanta metro area. I moved here from New York, so to all you New Yorkers up there, hey, I miss it a lot. We were supposed to be there this spring, but COVID. And so we're kind of anxious to get back to the family in Brooklyn, because the kids are kind of going through their withdrawal from New York. But I'm a pelvic floor therapist here in Atlanta. I work with men, women, and children dealing with a variety of pelvic floor issues. So anything bladder, bowel, pelvic pain, or sexual dysfunction related, I treat those things. I also work with a lot of athletes who are having pain and looking to get back into their sport, especially if they're Olympic lifters, CrossFitters, runners. I'm a volleyball coach and have played volleyball for way more than half of my life, on many different levels, international, collegiate, all sorts of things. And I also really, really enjoy working with the pregnant and postpartum community. I love to see the continuum from, preconception to pregnancy, the excitement, the anxiety going into birth, and then coming out of that on the back end, just kind of, all the emotions wrapped up in that, and just the journey. I really do enjoy that. And I've been very blessed to work with some amazing women and some amazing families. So that's been great. So one of my favorite things to talk about is sex and sexual dysfunction. I do see quite a lot of people in my practice who are coming to me with regards to issues with pelvic pain, sexual dysfunction, and a variety of other diagnoses that would cause them to have either pain with intercourse or just genital pain in general. So I do see a variety of people for that. One of the things, though, that I think is oftentimes overlooked, as some of you guys have already clearly indicated, is the fact that women don't really get a lot of information, education after they've had a baby, like to prepare them. Because people talk about preparation for pregnancy and preparation for birth, and there should be preparation for postpartum, because the postpartum period in and of itself, especially the early postpartum period, is going to be a whole new thing to navigate, right? It's going to be different. Now we've added one person. If you didn't have any kids before, you go from not having kids to like, oh my God, what is happening? And not that it is not a beautiful time, because it's absolutely amazing. I'm a mom myself. I would not trade my kids for anything in the world. But I do love my sleep, and I'm so glad that they learned to sleep through the night, because at that moment, it was probably the happiest time of my life, y'all. Winning lottery ticket probably would not have come close to a full night's sleep. That's how bad it was. But oftentimes we talk about sex after baby, and there are a few different research articles out there that give different percentages as to how many women are having pain with sex. So some articles say 65%. There's one in particular that says about 62%. I think that one was written back in 2015. There's one that says 47%. That was a little bit of a smaller sample size. There are some articles that go up to as much as 80% of women after having a baby will have pain with intercourse, at least within the first year. And then beyond that point, we're looking at least a third of women are going to have pain with sex, which is not something that a lot of women are prepared for, especially A, if they've never had sex before they got pregnant, or B, if they just automatically assume that at some point in time this would all go away and life would just carry on as normal. But it's one of those things that can be very frustrating, because it's not like you're having sex by yourself. I mean, it's always better with someone else. Well, sometimes. And that's one of the things that we'll get into as well. One of the other issues that women will have is, and it's not oftentimes talked about, there is some research, but there's not a whole lot of research, is the impact of breastfeeding and sexual function. And so, there's a huge push for breastfeeding because of all the benefits of breastfeeding. But we have to remember that when we're talking breastfeeding, we're also asking the body to multitask. We're asking the body to continue to produce milk to support the baby. That takes energy. That takes a lot of different things. And when we're breastfeeding, because of the prolactin, which is a hormone in the breast milk, when that's elevated, which is typical with regards to breastfeeding, what you'll find is the sex hormones drop. So the sex hormones tend to be lower. You got lower estrogen, you got lower progesterone, and your androgen receptors tend to be a little bit decreased. You tend to have a little bit less testosterone in there. So a lot of women will report, and it's typically higher in women who are breastfeeding, that they maybe don't have as much desire. A lot of women will report that that they're having a lot of vaginal dryness. Again, that one is correlated very much to the estrogen or the lack thereof. And so when we're talking about all these things after birth, that's going to be one of the things physiologically that jumps out. So if you're a breastfeeding mom and you have tried to have, and it's really not, it's really not that great. It's like, what's going on? What's happening? Give yourself a little bit of grace, because your body is going through a lot of changes, and it's going to be super important that you kind of keep that in the back of your head. And there are ways around that, but just kind of keep it in the back of your head that your body is currently multitasking. So something had to give, and it was the sex, because the baby's way more important than your sex life. And then the other thing is that we have to look at the notion of context, which is one of the things that I talk to moms about a lot. So if any of you guys, oh gosh, let me try to remember her name. I can't remember the name of the author. But the book is Come As You Are by Emily Nagoski. It is an amazing book. If you want a book to read about sex, about sexual pleasure, You need to read that book. I think for a lot of people, it will kind of reframe a lot of the thoughts that you have around sex and kind of give you a renewed perspective when it comes to sex in your sex life. Because one of the things that I like the way she phrased it, but one of the things I often talk to moms about is context, right? It was you and hubby before, especially for those first time moms. It was just you and hubby. You could have sex anytime, any place, whatever, whenever, however, wherever, no problem. Now you've got this person. So it's like when you're not up taking care of this person, you're probably tired. There's other stuff that needs to be done, which is also at the forefront of your mind. So it's almost like the more stuff you have to do, you kind of keep pushing the sex back. And so sometimes it's not so much that you have a lack of desire, but we also have to recognize that there may be a lack of opportunity, because now we don't have as much opportunity to engage in sex as we used to, right? And so that's something to bear in mind as well. So a few things that I often recommend for my moms, and these are my top 5 when it comes to postpartum sex, is one, make sure that you find a pelvic floor physical therapist. If you're having sex, if you've attempted intercourse and it is painful, sometimes before you even get to intercourse, what you might find is lochia has ended, which is the bleeding that you have after you had your baby, and maybe your regular menses have restarted. And you try to insert a tampon, and that now is a little bit uncomfortable, right? So if you're noticing a little bit of pain with that, especially if that was something that wasn't uncomfortable before, or if you've started having sex and you've noticed that that's become painful, go ahead and see a pelvic floor physical therapist, because oftentimes, we've got to think about the scarring. If we've had any perineal tearing, that can also affect our sensation, level of trauma from the birth. So if you've had a long delivery, if you were laboring for a long time, that's a lot. There are some women who will tell you, I labored for 20 some hours. And I kind of liken it to a marathon. Marathon runners typically finish in 4 hours, on average, in 4.5 hours. You're laboring for 20 hours. If you're laboring for 20 hours, you've run a few marathons. Your body is bound to be tired. So just to kind of put it in perspective for you. So with that, there's gonna be some irritation. There's gonna be some tissue sensitivity, maybe a little bit of scar tissue, things like that can happen. And so when it does, let's go to the pelvic floor physical therapist so we can get some work done in those arenas, and they can also give you some good tangible things that you can do on your own at home to help address that as well. The other thing that you need to do is you're gonna have to communicate with your spouse. Now, ladies, postpartum is an emotional time for some women, okay? So hear me out. Even though we want them to know what we're thinking, they can't mind read. We want them to be able to mind read, but they can't mind read. So we kind of have to usher them along, okay? So talk to your partners. Let your partners know what's going on. If you don't want to have sex, then don't. If you don't feel like you're ready, that's okay. Understand and know that that is okay. Talk to your partner so that they can get in on it, and they understand as well, like, hey, you know what, maybe this still hurts, right? Things just, I don't feel comfortable as yet. Things of that sort, because then what that's going to lead to is, well, if we can't have intercourse, what are some other things that we can do to maintain intimacy in our relationship? What are some of the other things that we can do? So for your own selves, you can do a lot of self-exploration. I always will tell women, especially postpartum, using just a lubricant and your fingers. Let me get my pelvic model real quick. So using some lubricant and just kind of going around, the vulva, the labia, the perineum, getting in on the inside of the labia majora, things of that sort, but just kind of massaging and just getting an awareness of sensation. How does it feel? Does it feel good? Does it not feel good? Because guess what? There might have been things that before you had this baby felt great. And then there's some things that since having this baby might not feel so good. So be mindful of that. But the best person to know that and to assess that is going to be you. So go ahead and make sure that you're doing that. But also, if you're comfortable and your partner is comfortable, they can get in on the action. And then we're starting to look at non-penetrative intercourse, which is way more fun anyway, because 70% of women aren't going to orgasm with penetration. So you're more likely to probably orgasm if you have some extended foreplay and extended exploration, which keeps you happy, keeps them happy, and just, and then we can keep it moving. So just be mindful of that. So that was get a pelvic PT. We want to communicate. We want to we want to make sure that there's a lot of self-exploration. The other thing that you need to consider is lubrication. Remember I said, if we're breastfeeding, even if you are supplementing while breastfeeding, you're still breastfeeding. So because your body is producing the prolactin, you're still likely to have decreased levels of estrogen, which is going to lead to that vaginal dryness. So you want to be mindful of that. And so what we need to do is we need to make sure that we're using a good lubricant when we're having intercourse. So I oftentimes will tell women a water-based lubricant. Most of the water-based lubricants typically don't tend to have any added extra stuff in them. So there's probably less likelihood of irritation and things of that sort. As you progress, with your self-exploration, if you decide to use a toy or hubby decides to use a toy with you, then you can use a water-based lubricant on the toys if the toys are silicone. If we're using a silicone lubricant, that can kind of degrade the material a little bit. So we don't want to use a silicone on silicone. That's usually the recommendation. But silicone lubricants are going to also be really, really good because they tend to hold that lubrication a lot longer. And then there are the oil-based lubricants. There's aloe, there's coconut oil-based lubricants, things of that sort. So again, find what works for you, find what feels good for you, and use that. And then we also have to consider, going back to the communication, you might have to schedule sex. So you might have to be like two horny teenagers and be like, what are you doing later? What are you doing at this time? The baby's taking a nap at like 2 o'clock. You want to get an afternoon snack? Yeah. And like come up with a code word, because you might go somewhere. And I'll tell you guys a funny personal story. We had a code word because I told my husband, like, if we would go visit family, like, I'm like, dude, it might be a great day. So if I shout the code word, or I say the code word to you, you need to be able to make an exit, right? And it became something that for us was fun and we would laugh at, because nobody else knew what the heck we were talking about. So it was great. We were like two little giddy-headed teenagers. It was fabulous. So I mean, even things like that you might have to do, again, because there's a lot going on. And if we talk now about multiple kiddos in the home, then now you've got multiple little people that you've got to be concerned with and you're doing stuff with, and this thing and the next thing, maybe, if you're working, if hubby is working, there are a lot of moving parts. So sometimes you may have to schedule until you get into a groove to where you can get back that spontaneity. Okay. So I wanted to kind of touch on those things first. Some of the other things that women will complain of during pregnant or after pregnancy with regards to sex is, what about if I have a prolapse? And so a prolapse is, all prolapse means is descent. And so what's happening is that the pelvic organs are descending. One, because either during pregnancy or rather postpartum, because of the delivery, we have had some overstretching of some of the ligaments that suspend them in place. Or we may have, some weakening of the pelvic floor, which is usually the case. And so they tend to descend down a little bit. So they descend. So for instance, there goes my bladder. Oh boy. So this is the bladder, this is the uterus, and this muscular wall here is the vagina. And the bladder sits right here. And the pelvic floor kind of is like a sling right here. If the pelvic floor is weak and they start to buckle, they descend. But remember, we also just had a baby. So this muscle, the vaginal wall, is going to be stretched out a little bit. And so now the bladder is going to kind of bulge into that. So it's almost like you're seeing it coming through, you know, like if I have a shirt here, it's coming through on the inside. So I'll show you that right here. So it's like if you've got something imprinting on the inside, that's pretty much what happens with the prolapse. The organs descend and they're pressing onto the bladder, they're imprinting onto the bladder. Now that's going to cause you some issues with sex because the penis has to go through here. So if there's anything imprinting, there's anything bulging in the vaginal canal, then that's just a blockage. It feels uncomfortable. It may cause you some discomfort, some pain. And so here are a couple things to be mindful of with that. For one, positioning is going to help substantially. If you have a bladder prolapse, which means that the front wall of the vagina is weakened and we've got bulging there. So it's bulging through the front. We're going to need gravity to be our friend. So anything that puts you now on your tummy, anything that puts you in hands and knees is probably going to be a little bit better than if you were, say, in missionary and doing it, or even sometimes in sitting, like if you're sitting on top. So, and that's just an example, because we want to be mindful of the prolapse. Again, if you're having issues with the prolapse, these are the things that your pelvic floor therapist is going to talk to you about. So that when you're going to these sessions and, you know, you have a known prolapse, or they've determined that you do have one, or your OB might have determined that, then we can say, okay, now let's talk about sex, because, and I usually talk about sex very early on because I don't want my moms to be alarmed. I don't want it to be something that completely takes them by surprise, because what happens is they have the baby, you go 6 weeks, you don't see anybody, you go to the physician who says, you want birth control? Or are you ready to tie some tubes? And that's pretty much the extent of the conversation. There's not really a lot of dialogue with regards to, you know, outside of now you can start to have sex. There's nothing really more outside of that. There is no preparation in terms of, well, be mindful of this or do this or whatnot. So a lot of women, when they do have that first experience after having a baby, it's like shell shock. They're like, what the heck is happening? So just be mindful of that. Oftentimes the research will show too that with women who are younger, or women who've only had one baby, women who've had more than one baby, or women who are younger, those two groups tend to ease back into sex a little bit quicker than, say, if it's the older mom, especially having her first baby. But the younger moms oftentimes tend to go back into sex. Now, granted, they may resume sexual activity, but it may not necessarily be comfortable, but they're more likely to resume than someone else who, you know, is having multiple kiddos and a lot of pain, older, things of that sort. So I'm going to go ahead and pause there and look and kind of let you guys ask some questions now, and kind of get a sense of where, you know, what questions you have, things that you kind of wanted to know about, or whatever the case may be. So if you guys have any questions, let me go ahead and read the chat here. And Alexandria, thank you for posting that. So there are quite a few different places that you can find a pelvic floor PT. You can find them on pelvicguru.com. They have a directory. You can find them on the Pelvic Rehab, which is the one here. You can also find them on the Academy of Women of Pelvic Health, or for the American Physical Therapy Association. They all have directories, and you can typically go on there and find a pelvic floor therapist in your area. Some of us are licensed in more than one state. So for example, I'm licensed in New York, Georgia, and Florida. So, some of us are licensed in more than one jurisdiction, and oftentimes social media. So sometimes you might just say, hey, do you know somebody in my area? You know what I mean? Like, do you know somebody? And if you're following any professionals, sometimes just ask them, because they'll know more often than not. And if they don't, they probably know somebody that does, and they can point you in the direction of a pelvic floor therapist in your area. All right, so the questions are coming in. So the first question, what are the typical symptoms of pelvic floor prolapse? So pelvic organ prolapse is typically associated with a heaviness, a feeling of heaviness. It usually gets worse closer to the end of the day. Sometimes you have issues with urgency. So you either have hesitancy in your urine stream, like you go to pee and it's like, pee, stop, pee, stop. It's not like a steady urine flow. It's a very stuttered type of urine flow. Or sometimes it's just a really, really hard time. And again, going back to the example with the bladder and the vagina here, this is the urethra. So this is a tube that exits the body right above the vagina. So it'll be right here where you see this is the vaginal opening, and that little dot right here is the urethra where you pee through. And so what happens is this tube, if you will, sometimes can get a kink. It's because obviously if the support structure is gone, then that changes the positioning. So it also will change the position of the urethra. So sometimes when you go to the bathroom, you feel like you gotta pee because your bladder is full. But when you go, you can't start that urine flow. So those are some of the symptoms that you'll feel typically with having a prolapse. You might also have a feeling outside of just some very, very low line abdominal pressure, kind of usually above where the pubic bone is, kind of around that bikini line area. You might also notice a feeling like something is about to fall out of your vagina. So, some women either will see stuff hanging, or some women might say, I just feel like something is going to fall out. I had a mom who had a baby, and it was her second. She also had something called Ehlers-Danlos syndrome, which is a disorder related to tissue connectivity, and the tissues just tend to be a lot more lax. And so she didn't have any pain, she didn't have any pressure. She only knew there was a problem when she tried to go poop, and part of it was she was straining. So we then had to talk about toilet hygiene and things of that sort, because she would go sit on the toilet and she's like, oh, something just came out and it wasn't my poop. And then she just push it back up and she keep moving, and so she actually birthed with a midwife. And so she told the midwife, and that's how she ended up coming to me. But yeah, so those are kind of the symptoms that you'll find with the prolapse. So the next question here is, let's see, does a C-section affect the pelvic floor differently? So oftentimes women will assume that because they've had a cesarean that there will be no pelvic floor issues. When you're pregnant, your body still goes through all the changes. So you're going to have alignment changes. Baby is growing. The fetus is growing here, and usually what's happening is we get a little bit of that pelvic tilt coming forward, that little bit of an arch. So we're still having some of the orthopedic issues because muscles attach to bone. When we change the bony alignment and we change that, sometimes that can impact the muscles as well. So it really doesn't matter if it's cesarean or vaginal birth. The other thing is that if it wasn't a planned C-section, then what you're going to find is if the women have labor, they're still getting that pressure, that perineal pressure, that pelvic floor pressure, as a result of laboring and as a result of the baby descending. So oftentimes those women will still have issues with their pelvic floor. If they haven't done that, and let's say it was a planned cesarean, then you also can have a lot of pressure, because with lightning, when the baby starts to descend round about 37, 38-ish weeks usually, and the baby starts to descend, and that's how we know, when everybody says, oh, your belly's dropped, then that puts a little bit of pressure onto the pelvic floor. So those are things to be mindful of. So short answer is you can still have some pelvic floor dysfunction even though you had a cesarean. Let's see here. These are good questions. Let's see, what are questions we should ask for OBGYN regarding pelvic floor? So some OBs just don't refer to pelvic floor PT because some OBs just have no idea what we do. They just have no clue. I have spoken to several OBs. I have had lunch and learns with several OBs and midwives, and they're still in awe because most of them are just like, oh, you can fix that? And I'm like, yeah, there's lots of research. You didn't see all the research? And, so things like prolapse. I had a lady who came to me because her physician was recommending surgery for a grade 2 prolapse. And there are 4 different stages of prolapse. So the grade 2, it's not coming outside of the opening, right? It's still at least a centimeter within the vaginal opening. And he was recommending surgery, but her symptoms were really bad. And she was kind of scared. She's like, I don't want to do surgery. Is there anything I can do first? And so someone recommended pelvic floor PT to her. And I mean, within like 3 sessions, I worked with her for 6 total sessions. And within about 3 of those sessions, her pain, like the pain that had her doubled over on the sofa and all that stuff was gone. She was actually confident enough to resume intercourse after that 3rd session as well. And so a lot of the time, these are the things that I'm having to tell the physicians, like, hey, I just saw your patient and they're doing really well. Here's what we're doing, just so that they're aware, and they're aware of the progress as well, so that it can kind of clue them into, oh, that actually works. Because truthfully, some of them just don't know, and you don't know what you don't know. So when you go to the OB at 6 weeks, I just usually tell women, just get a script for pelvic floor PT. Just tell them to write you a prescription. Just don't even hey, can you write me a prescription before I leave here? Like, just actually give it to me for pelvic floor PT. And not that you need a script in every state, but the direct access laws are different from state to state. And so some states have unrestricted, and some states they might be able to evaluate you, but they'll still need a script at some point in time. So I just have them go ahead and get one. So that would be a good thing to ask. Let's see here.
I just wanted to interrupt for a second while you're reading the next question and echo that for our clients, like for students that we teach and then we follow up with them postpartum, the vast majority of the time their care provider is telling them not to do pelvic floor PT or to wait until they're done having babies to sort of deal with their issues. And we encourage everybody as a baseline to get checked out. So that's just what I would add for people who are on the fence about it.
Mm-hmm. Yeah, because a lot of them just don't know. I had one physician I met, and I was kind of glad that I met him. It was at a holiday party, actually. So his group was throwing a holiday party a few years ago, and we were having the conversation, and he was like, oh yeah, when women leak, I just give them Kegels. I said, well, what about the athletes that haven't had kids? He's like, well, they shouldn't be leaking. I said, but they are. So you're going to just give them Kegels too? And he was like, well, what do you do for them? I said, you send them to me. And he was like, oh, but why are they leaking? And so by that point in time, he was intrigued because in his mind, the only women that leaked were women that had a baby or older women. And so that was kind of his tunnel vision focus, but he was totally unaware of anything else. So someone asked about stitches and scar tissue. So if you've had to have stitches because of tearing, there are 4 different degrees of tearing. You can have slight tearing. You can have tearing through the frenulum here. You can have tearing through the muscles here. You can have tearing up to, but not through, this sphincter here, this anal ring, and then you can have tearing through there. The more tearing you get, so when you get into that grade 3, when you get around the musculature of the anus, and then you get through that anal sphincter ring, those tend to be more severe. Those are the ones that are going to result in sometimes fecal incontinence. Those are the one where you have less urinary control. Those are the one where you have a lot more scar tissue. And if it's a very, very bad tear, like a really traumatic grade 4, sometimes they may go ahead and just do opt for like some doctors opt for like a reconstruction. I've had a couple clients that have ended up having that as a result because they just had a very traumatic birth. So ultimately, what you're going to do, you need to make sure that the tissue here, anytime you have the stitches, scar massage is going to be super important. But more so, you want to start, this is one of the reasons why I'm a big proponent of just self-touch, because you don't want anybody else down there, because that's what you're already thinking in your head. So the only person that then can do this is you. You want to just go ahead and start touching around the muscles. So if you can go ahead and start kind of getting a sense of, can I feel this? So what is the sensation like? You know, if I touch here, do I have tingling? Do I have pain? Obviously, if you're having any of that stuff, I'm going to tell you to go straight to pelvic PT, but you want to get a sense of what's going on in the area. And then ultimately, one of the things that you would do, or you'd be instructed to do, is some sort of perineal massage, and some sort of massage either in through here, and then also at the vaginal opening, so that it's going to be more of, kind of think of that perineal massage you did for childbirth preparation. So it's going to be like that as well, but just kind of working on getting the tissues to loosen up a little bit, because oftentimes when you've got a lot of those stitches, that's typically what happens with most women. They tend to get a little bit of scar tissue. It tends to be really, really tight. And because it's tight and because it is, it's really uncomfortable, sometimes they may also tighten more as well. So then we end up getting into a situation where the muscles are being clenched a little bit more, and that could lead to some hypertonic pelvic floor. So again, making sure that we are having that addressed. Yes, you can have, so someone just asked if you can have scar tissue deeper. Yeah, because the baby, remember, the baby is coming through here. So this is the birth canal. The baby is coming through here. And with the baby coming through here, like this is my fist. Look at how small the vagina is. Like seriously, y'all. So like, and this is just my fist. So like try to get this through that. It's intense. So and you usually will find that the longer the labor, or sometimes if the baby is not necessarily in the best position. So these are the types of conversations that you need to be having with your birth workers, with your midwives, with your OBs, with your doulas, because what's happening is, you know, if the baby is not in an optimal position, if the baby is sunny side up, if the baby is breech, if the baby is not turned all the way, because we want the occiput posterior, we want the back of the baby's head to be, you know, to be, we want the back of the baby's head actually to be here, to be right here. And so what's happening is if the baby's not in that position, it just kind of makes it a little bit more difficult to come out based on the way that babies typically rotate coming out. So you might have a little bit of harder time. Baby might take a little bit longer to come out. You might have that labor is going to be a little bit longer. And if we kind of think of that pushing process and the labor process and the contractions, and then we kind of extrapolate it out based on duration of time, you can see why you might have some irritation and some scar tissue in these muscles higher up as well. Okay, so it is very possible to have that. That is also something that we address, and that's where you get into a lot of the internal work with pelvic floor physical therapy, because we start addressing those issues with the muscles. There are some women that because of that may have decreased sensation, because the pudendal nerve runs kind of right around this area right here. And so, and it runs under a couple of the muscles through a little canal of connective tissue. And if you've got constant movement of the baby down, so there can be some irritation in that area. So either you can end up with some pain postpartum, or you can end up with some decreased sensation postpartum. So there are a few things that could happen. But again, you know, this is not going to happen to everybody. It certainly can. But if you're noticing these things, then you definitely want to have them assessed postpartum. Let's see here. Bear with me, guys, because I'm on my phone, so I have to like go back and forth from the screen. So someone is saying that they have, let's see, wait, okay. So I find myself wanting to go back and get records for my first birth and learn exactly where I tore and had stitches because I still have discomfort. Yeah, and it goes back to that that concept of, again, if it's painful, what do we do if we hurt? We kind of pull away, right? So like if my arm was hurting, I want to keep my arm closed. We call that a primitive posture. It's a neurological reflexive response that we automatically assume. So if something hurt, like if you burn your hand, you're not just going to leave your hand out there, right? You're going to be like, oh man, like, you pull it close to your body. And so what happens is if you're realizing that these tissues hurt, it hurts with penetration, then what you tend to do is you start guarding a little bit. And now if you're guarding, and those muscles tend to become overactive, one of the things that happens with that, the overactivity of the muscle and the constant clenching of the muscle causes compression of the capillaries, which decreases some of the oxygen in and around the area, and it causes this little pain loop, because if you don't have enough oxygen, then that can result in pain. You compressing the nerve endings in the capillaries, that's going to result in pain, and it's like this nice little loop of stuff that's happening. All because we were already in pain. It was already kind of an uncomfortable situation, and so we're trying to avoid any more discomfort in the area. So it's our body's natural instinct to protect ourselves, and so we're like this. All right, does that make sense? So let's see here. I'm gonna start reading from the bottom. Are these kinks what causes the dribbling and leaking when coughing and sneezing? So what you'll find with those kinks is that's what's gonna cause when you go to the bathroom and you pee, and then you stand up and you dribble. So, or you stand up and you feel like you've got to empty, because what happens is there's a sphincter that lets the internal sphincter is right here. Let me turn my video on. So the internal sphincter is right here at the bottom of the bladder, where the bladder and the urethra meet, and then coming out, there's another one. Once it's already out of the bladder, you actually will not have that much control. There's not a whole heck of a lot that you can do. So once the fluid is out of the bladder, you go to pee, you go sit down, you think you've emptied. Well, then you've still got a little bit in the urethra. And especially if the urethra has been stretched or whatnot because of the delivery and whatnot, and you've got a prolapse. And so you go to get up, maybe you go to wash your hands and you're like, wait, I'm not done, I gotta go back again. And we call that double voiding. Or as soon as you stand up, some more trickles out. So that's usually what's gonna occur with that kink. And someone else asks, after sex, I feel pain in the pelvis, like I've been punched. How would physical therapy help? Well, for one, we gotta figure out why you feel that way. We've got to figure out where the issue is coming. Are you having an issue with penetration? With so initial penetration? Are you having an issue with deeper penetration, and why? Sometimes for a lot of women, there may be an undiagnosed prolapse, which may not be the case with you, but it could be. So for some women, it could be an undiagnosed prolapse. For other women, it could be some residual scar tissue in the area. And so it's just a matter of working on those things. Sometimes it's also the fact that if you have had any pain, so when we talk about things like muscle memory, if you've had any pain with intercourse, and so now even though you're having sex, if initially you had a tendency to clench, sometimes that tendency persists. And so what you might notice is there may still be some hypertonicity in those muscles. Those muscles may still be clenching a little bit, and we want to make sure that we're addressing them, so that as you're engaging in intercourse, you can be completely and totally relaxed, and the muscles aren't just clenching excessively and adding to your discomfort. So that's something to be mindful of. And let's see here. I'm trying to get through as many questions as possible because I know our time is almost up.
I can read one that was sort of in the middle. So for orgasm sensation with self-stimulation or with a partner, when that's diminished or just not fun, she says, I haven't heard anybody talk about this. So just,
So
yeah.
an orgasm, so are you speaking specifically that you can't achieve an orgasm? Because there are some women who have, again, one of the things that we recognize is that after childbirth, there are going to be some changes. There are going to be some tissue changes. There may be some sensory changes. And so sometimes with a lot of women, they may not orgasm. Well, now we need to figure out why. Are we not orgasming because of, maybe things have changed, maybe there's some overstretching or something like that? Are we not orgasming because of decreased sensation? And then if that's the case, we need to figure out what's going on. Because and you said orgasm takes place, but it's about a tenth. So sometimes that could be a result of decreased sensation. So you're not getting that heightened climax like you used to. And that's something that needs to be addressed as well, because now if the sensation isn't there, why is that? Is it something that may return eventually? Is it something more going on? That's where your assessment is going to come in. Having that pelvic floor assessment so we can look at that. Could there be some nerve involvement or, things of that sort? Oftentimes, so again, only 30% of women will orgasm with vaginal penetration. The other 70% are through clitoral stimulation. There are a lot of women who typically would orgasm vaginally that after they've had a baby, they don't. Some of them never do. Some of them are able to, but it takes some time. So we've got to remember that our bodies are going to take time to heal. So it's going to take some time for just everything to get back to some semblance of normalcy. Those tissues were overstretched. If they were overstretched, then we also have to consider, again, sensory input. How is the sensation in the tissues? When with penetration, are you aware of the penetration? For a lot of women, what they'll say is, I know that the penis is there, I just can't feel that the penis is there, or I don't feel it doesn't feel like much, because they don't have a good amount of sensation postpartum as they would before. And sometimes it's healing. For some women, it's just healing. And for other women, it just takes time, and they may need a little bit more than that. So it's one of those things that's definitely going to be addressed on a case-by-case basis, because you really want to know the root cause, like what's going on that might be causing this. Where is the decrease in sensation coming from? What is happening with the muscles? Because usually with orgasm, there's also spontaneous muscle contraction. And so sometimes that's not happening. Well, if the muscles are weak and they're overstretched, you can't expect that to happen either. So sometimes that could be a part of the problem, because when you get to orgasm, how the muscles just start to contract on their own. But if those muscles are overstretched, right? And so now we kind of think of, one of the easiest analogies to give is if you have a rubber band that's still nice and taut versus a rubber band that's really stretched out. If those muscles are overstretched, they're not going to give you that sensation with an orgasm as they would before. So again, that goes back to some of that pelvic floor strengthening that you might need if that's your particular issue as well. Let's see. See if I missed any more.
There was one question, and maybe that will be the last one, about scar tissue. Like, what strategies are there for manipulating scar tissue or making it more pliable?
Yeah, so again, with the scar tissue, we talk about perineal massage. It really just depends. There are different things that you can use, different tools that you can be guided on, a pelvic wand. Sometimes depending on the stage my clients are at, in particular in their rehab, then I may start to introduce any type of vibratory tool. So any type of tool. So there is a vibrating pelvic wand. I really love to use those. I also will recommend sometimes using a vibrator, especially the more slender ones, just because that now can start to stimulate a little bit more sensation. Now, that's not going to work for everybody, because there's some people who are going to have a significant amount of discomfort. They're going to have a significant amount of discomfort. And so any sensation is going to be uncomfortable for them. So we don't want to go do vibration on them. Again, this is where that assessment comes in, so that we know what's going to be appropriate. But certainly if they can tolerate it, then a little bit of vibration, maybe on a low level, so that there's a low level stimulus. So for one, you can start to stimulate some more sensation. But then for two, it has a little bit of a massaging or a relaxing effect, right? Think of putting something that vibrates on you, you kind of get, oh, look at the pumpkin. And you kind of get that relaxing effect. It's kind of the same thing. So there are a couple of different tools, like I said, you know, we could utilize the pelvic wand, manual therapy, doing perineal massage to try to help with scar tissue. It's not going to be an overnight process. It's not going to be an instantaneous thing. It's going to take some work, and it really is going to also depend on the severity of your scar tissue. Did you tear a lot, right? Did they stitch you? There's a lot of women who, I remember having, I did a workshop for a doula group a few months ago, and so I had a whole bunch of women come in who they were, you know, working with all these different doulas. And they were talking, they were like, so I've got all this pain. And, you know, then we started talking about something called the husband stitch. So the husband stitch was this extra stitch that they used to put, it really, like, when you start talking about these things, you really have like less love for men, God bless them. But they used to do this extra stitch called the husband stitch when they were sewing perineal tears, either from an episiotomy or from a natural tear. And they would sew it, and then they would do an extra stitch to make it tighter for the husband. God bless them. So yeah, so for some women, I would always ask, when you had stitches, if you have any type of tearing and you had to get stitches, I always tell women, ask, be curious, you know, what did they do? Find out what they did, because for some women, they could be completely fine. And for other women, there is just a lot of tightness and irritation, which could be as a result of the stitch. If you're early postpartum, it may be that sometimes, even though they use the dissolvable stitches, if there is a knot, sometimes they don't dissolve as well, and they have to go in there with the little tweezers and pull them out. Or sometimes they may fall out on their own, but sometimes they can be very irritating, you know, because not all of the stitches dissolve sometimes. So just be mindful of that. But again, perineal massage, you know, seeing the pelvic floor physical therapist to have those things addressed. And they will, you know, based on what you've got going on, they're also going to go ahead and work with you on your specific condition, you know, whatever it is specific to you, your muscles, your, you know, whatever level of weakness or pain or whatever, so that they can work on that specific to you and give you all the tools that you would need for you specifically. There are a lot of other things. I know someone had mentioned something here a moment ago in the chat for a lot of women so I've worked with Lynn Schulte, and Lynn is awesome. I've worked with Lynn, and you know, and it's just, we do a lot of manual therapy techniques. So like visceral mobilization and trying to work with a lot of the tissues, because again, a lot of women may have abdominal pain, you know, even outside of a cesarean, after they've had the baby. You know, women may still have issues with breathing, you know, like, I can't catch my breath. And so we may have to work on some restrictions in through the diaphragm, things of that sort. So there's a lot of work that can be done. It really just depends on what's going on with the individual mom. Not everybody's going to need everything, and some people may need everything, you know, but it just really depends on what mom has got going on and, you know, what specific things need to be addressed.
Can I ask one more question that came to me privately? We're like at time. Okay. So someone gave birth 10 weeks ago and has vaginal pain, especially at night when laying down. She had a 9-pound, 8-ounce baby and a fast delivery. It's her second child. It's a throbbing, burning, stinging sensation. Is this normal, and how long does it typically last?
Definitely, stabbing, burning, stinging is not normal. So if from the time you mentioned stabbing, there are a couple things that I would be mindful of. Have you been assessed for a prolapse? One. Stabbing, you automatically think neurological pain. Or neurological involvement. So I would be curious to know what her pudendal nerve, what's happening there, and kind of getting that addressed. So yeah, you would definitely be a great candidate for pelvic floor PT to have that stuff addressed, you know, so that you can get that pain alleviated. As far as how long it's going to take, just varies from person to person. It really does. It really, really does.
Yeah. Oh my gosh, this was like packed full of information. Those were such good questions, everybody. And also, I'm sorry they were good questions because it means people are dealing with a lot. But it, like, we're in good company, right? Like, this is just the thing that we go through. And I'm so grateful to have someone like you here sharing and giving people advice. Hopefully everybody who's still pregnant and has just had their baby, like, you don't wait like Lisa and I 6 and 15 years to sort of figure our stuff out. Okay, so I'm going to send a follow-up email to everybody with your Instagram handle again and your website, because you're doing virtual sessions now so people can see you, right? If they're in New York or Georgia or Florida.
New York, Georgia, Florida, I do virtual sessions. If you're here in the Atlanta metro area, I offer home visits for my moms. That's a service I offer specific to my moms, whether they're pregnant, postpartum. And I also do some birth prep and birth coaching. I'm a birth doula, so I also do that to try to, because one of the things that I find is prior to doing that work, you know, I would have women coming to me and going, but a lot of this could have been resolved during your pregnancy. And so one of my reasons for getting more into birth doula, and I was doing some birth coaching before, but with some of my clients who requested it. But one of my reasons for getting more into that is just to get into the community, because like I know doulas, but God, there's so many different doulas out there, and so just kind of get into the community. But to also be able to get women early as possible so that we aren't having a lot of these issues on the back end. And also, if some of these things are unavoidable for whatever reason, to make sure that at least they're educated and they're aware, so they're not, you know, blindsided once they've had the baby and wondering what the heck is going on and why is my body failing me. So.
Yes, I agree 100%. Okay, I'm sure everybody has such, like, I don't know, dinner plans. That's probably all that's going on now, but thank you all so much for joining us. I will send a follow-up email with all this information. Please stay in touch with both of us on Instagram or email. We're available, and yeah, okay. Thank you, guys. Next week, we're talking about returning to running with another physical therapist. If you are postpartum and you are a runner and you want to join us for that conversation, I think it will be interesting. Or, you know, doulas, and everybody is always welcome. Okay.
Yeah.
Thank you,
awesome,
guys.
Thank you so much. Bye.
Bye.